handover is conducted in line with the NSQHS Standard 6 and more specifically Standard 6.2, which refers to a structured process to guide clinical handover. Graham Jones is a 64-year-old male who was admitted to the emergency department at 6:30 a.m. Graham woke from his sleep as he was experiencing sudden severe chest pain that he described as crushing with a shortness of breath despite applying no exertion. The pain is on his left side and radiates down his arm. Despite attempting to ignore the pain, he says was worsening, it was not being relieved, and he began to feel anxious and stressed out about his pounding heart and tightness across his chest. Graham is considered to be overweight, has type 2 diabetes under lifestyle control, and suffers hypertension from which he has prescribed regular medications for. He also has high LDL cholesterol levels, low HDL cholesterol levels, and no allergies. He is a part-time truck driver with a sedentary lifestyle. He is a smoker, describing his habit as 25 pack a day. Graham has been assessed upon admission and his vital signs are as follows. Blood pressure 147/93, heart rate 120 beats per minute, respiratory rate 30 breaths per minute with visible work of breathing, oxygen saturation 92% in room air, temperature 36.5. The cause of Graham's signs and symptoms have not yet been identified. I recommend the following to be done. ECG monitoring, management of Graham's pain, promote adequate perfusion to the entire body, and some patient education.
The term acute coronary syndrome refers to any group of clinical symptoms compatible with acute myocardial ischemia, including unstable angina, atherosclerosis, non-ST segment elevation, myocardial infarction, and ST segment elevation myocardial infarction. These conditions include a gradual buildup of plaque in the lumen of the coronary arteries, which cause a reduction in blood flow to the heart, leading to chest pain and potentially an acute ischemic event. Furthermore, the atherosclerosis coronary artery plaque built up in the artery can be interrupted by either of the following ways: rupture or erosion. Once the atherosclerotic plaque has ruptured, subendothelial matrix proteins and other molecules are exposed, which results in platelet adhesion and a subsequent formation of a thrombus. Following this, arterial clots can be formed through two of the following pathways: activation of platelets and generation of thrombin by coagulation factors. There are two types of thrombi that can be formed: a platelet-rich clot or a fibrin-rich clot. It is this coagulation of platelets and red blood cells which causes further occlusion of the already narrowed atrial vessel, leading to a sudden and significant reduction in coronary blood flow and myocardial oxygen supply. Development of acute coronary syndrome is influenced by relevant risk factors such as smoking, hypertension, obesity, diabetes, all of which Mr. Jones's current and past health history consists of. These are potential complications which may be the cause of Mr. Jones's current condition. Obesity. Having obesity can have negative effects on the cardiovascular system. Some of these include increased insulin resistance, elevated blood pressure, dyslipidemia, heart failure, and coronary artery disease. Mr. Jones's BMI is 29, classifying him as being overweight. Therefore, he's at risk of these negative effects. Dyslipidemia is often related to obesity, smoking, unhealthy diet, and a lack of exercise. It increases the chance of atherosclerosis due to an elevation of plasma cholesterol, triglycerides, or both, or a low, high-density lipoprotein level. As the cells are deprived of oxygen due to the blockage in the artery, ischemia develops. Cellular injury occurs, and over time, the lack of oxygen results in infarction or cell death, leading to acute coronary syndrome. Diabetes greatly increases the risk of acute coronary syndrome, especially in type 2 diabetics who are insulin dependent like Mr. Jones. This is due to a poor response to platelet inhibition, resulting in more platelets recruited to the site of rupture and therefore further narrowing the artery and leading to cardiac dysfunction. Abnormal cholesterol and high triglyceride levels. Patients like Mr. Jones with diabetes and a high BMI often have unhealthy cholesterol levels, including high amounts of low-density lipoproteins and low amounts of high-density lipoproteins, as well as elevated triglycerides, which also contribute to the buildup of plaque within the artery. These elevated levels of unhealthy cholesterol is a characteristic of a lipid disorder associated with insulin resistance, called atherogenic dyslipidemia or diabetic dyslipidemia, in those patients with diabetes which further occlude the artery. A lack of physical activity. Lastly, due to Mr. Jones's sedentary lifestyle, physical inactivity is another major risk factor. As mentioned previously, being overweight often includes having an unhealthy cholesterol levels, type 2 diabetes and hypertension, which therefore shorten the onset of acute coronary syndrome. Hypertension. Over time, Mr. Jones's hypertension has added extra pressure against the artery walls. This extra pressure damages the arteries, making them more vulnerable to a narrowing and plaque buildup associated with atherosclerosis, which the narrowed artery limits or blocks the flow of blood to the heart muscle, depriving the heart of oxygen. Mr. Jones's signs and symptoms of crushing chest pain, shortness of breath, pain radiating down the left side of his body is a good indication that he may be experiencing acute coronary syndrome. These signs and symptoms, along with his past health history and lifestyle, need to be taken into consideration to determine the most appropriate interventions.
Medications we chose for our patient. Aspirin is an antiplatelet medication used for the treatment of fever, pain, and inflammatory conditions. Aspirin is also a common first-line treatment for patients showing signs of myocardial infarction or chest pain. Aspirin prevents the formation of blood clots by inhibiting thromboxane A2 production, which in turn increases blood flow to the myocardium. The use of aspirin can be continued as a preventative measure for patients with acute coronary syndrome. In our case scenario, Graham has presented with acute chest pain, along with other signs of acute coronary syndrome, such as hypertension, tachycardia, and decreased oxygen saturation. It is advised by the National Heart Foundation that aspirin is to be administered immediately unless it is contraindicated when warning signs are evident. It is administered orally and should be given with food consumption. Prior to administering aspirin, it is important to ensure that the patient has no hypersensitivities to the drug. There's also no known bleeding disorders such as intracranial hemorrhage or gastrointestinal bleeding, no severe liver impairment, is pregnant or breastfeeding, as these are all contraindications to drug administration. Informing the patient that they may feel nausea, vomiting, epigastric discomfort, heartburn, headache, and dizziness is important, as they are all common side effects related to the use of aspirin. Allergic reaction and internal bleeding are some other side effects. Graham's baseline status will need to be determined, including vital signs, skin colour, Glasgow Coma Scale, and reflexes prior to administering aspirin to assist when monitoring for adverse reactions to the drug. Glycerol trinate, or GTN, is another pharmacological intervention that has been chosen to treat our patient. It is a vasoactive agent that works by relaxing smooth muscles and dilating primarily the veins, but in high doses also the arteries, resulting in an increased venous pooling, which decreases the amount of blood returning to the heart. This helps to reduce myocardial work and restores the balance between oxygen delivery and oxygen demand. GTN can be administered in many ways, but the sublingual route is preferred due to it bypassing the liver where metabolism occurs, making the drug more effective. As our patient currently has low oxygen saturation and is suffering from hypertension and tachycardia, decreasing the workload of the heart is important in preventing further damage to the myocardium, especially as Graham has an increased risk of myocardial infarction due to his modifiable and unmodifiable risk factors. GTN is contraindicated when the patient is allergic to nitrates, anemic, or suffering from head trauma, cerebral hemorrhage, renal disease, hypotension, hypovolemia, or any other conditions that limit cardiac output. Adverse effects of GTN include hypotension, headache, dizziness, tachycardia, rash, nausea, vomiting, sweating, and chest pain. Care considerations after administering GTN include looking for signs of adverse reactions, which can be done by monitoring vital signs and noting changes in cardiac output and status. Morphine is an analgesia that's primary aim is to provide pain relief for a patient with moderate to severe acute or chronic pain. It is administered intravenously in increments to maintain and manage the pain associated with our patient. Morphine affects the central nervous system by acting as an agonist by binding to receptors and producing physiological responses. This assists with reducing anxiety levels and lessens diaphoresis as it acts on the autonomic nervous system. It also reduces preload, which decreases the work of the heart and relaxes bronchioles to enhance oxygenation. Graham has presented with acute pain and is quite anxious due to the inability to breathe. The properties of morphine will help with this scenario. Contraindications of morphine include hypersensitivity to the drug, respiratory depression, increased intracranial or cerebral spinal pressure, heart failure, liver or renal disease. Side effects of morphine include dizziness, drowsiness, sedation, nausea and vomiting, dry mouth, shock, constipation, urinary retention, physical dependence. After administering morphine, monitoring the patient's sedation level and cardiac response is important to prevent respiratory depression.
Frequently obtaining pain scores will ensure correct dosage is being applied and pain is managed appropriately. Okay. Carvedilol is a beta blocking agent that blocks alpha-1 adrenergic receptors, which results in decreased myocardial oxygen consumption, heart rate reduction, and lowering of blood pressure. For Graham, the use of carvedilol would be an initial pharmacological intervention combined with a secondary prevention measure. As Graham has a history of high blood pressure and is uncompliant with taking his prescribed medication, administering carvedilol will assist in reducing his high blood pressure levels, a factor contributing to his acute coronary syndrome. Using carvedilol rather than other beta blockers such as Antinol is preferred in diabetic patients as they are safer and more effective compared to other beta blockers that mask signs of hypoglycemia. Contraindications to carvedilol include hypovolemia, hypothyroidism, history of anaphylactic reactions, severe hypotension, advanced atrioventricular block, sick sinus syndrome, and heart failure. Some common side effects of the drug include orthostatic hypotension, fatigue, nausea, diarrhea, bronchospasm, cold extremities, dizziness, abnormal vision, and dysnopia. When taking beta blocker drugs, monitoring blood glucose levels is important to detect hypoglycemia, along with monitoring blood pressure and heart rate. When ceasing the medication, making sure it's slowly decreased will prevent hypertension and angina from occurring. The National Safety and Quality Health Service standard that is applicable is Standard 4 Medication Safety. Standards are to be followed to ensure patient safety when preparing, administering, monitoring, and documenting medications to prevent medication errors.
Initially, on entering the room to care for Graham, a quick assessment of his overall well-being will be undertaken, with the use of ABPU assessment. Viewing for a response from Graham as he is greeted by me at his bedside. Here I'll be recognising his work of breathing, his level of consciousness, whether he's replying or showing any signs of pain. Graham would present with insufficient cardiac tissue perfusion caused by a reduced coronary blood flow. The goal for us as nurses would be to relieve Graham's pain and discomfort in his chest and radiating pain caused by ischemia. Graham's vitals, including his blood pressure, respiratory rate, pulse, oxygen saturation, temperature, skin turgor, and level of consciousness will be observed. By viewing his vital signs, a conclusion on the effect of coronary ischemia on the heart can be made. Graham's pulse being tachycardic due to an increased workload of the heart to compensate for the atherosclerotic blockage. Graham's blood pressure being hypertensive due to the need for the heart to work at a strenuous rate to ensure adequate tissue perfusion. His respiratory rate elevated with an increased work of breathing being high due to a decreased diffusion of gases in the lungs and inadequate blood flow. Graham's oxygen saturation also being a little bit low due to a decreased blood flow, which does not allow for efficient gaseous exchange in the lungs. Level of consciousness will show the effect of Graham's acute coronary syndrome has on the brain as a result of poor tissue perfusion. Whether his skin turgor is normal or abnormal can conclude whether ischemia is causing insufficient perfusion to the peripherals. Pain assessment for Graham includes the use of PQRST. Here, I will ask Graham the characteristics of his chest pain, symptoms that accompany his chest pain, the site of the pain, when the pain began, where the pain radiates to, the timing of the pain, relieving or aggravating factors, and how severe the pain is. Graham would respond that he can feel a crushing and tightness in his chest that radiates down his arm, which has been continuous since he came to hospital. With both the pain assessment and vital signs taken, the cause and effect of Graham's chest pain can be concluded. This also provides a baseline of data for future assessment and the possible need for further intervention. Oxygen administration will then be applied as requested by the doctor. Oxygen administration allows for an increase of oxygen to Graham's coronary arteries. However, should be done so to reach a specific target range. Excess oxygen can cause vasoconstriction, leading to further occlusion of coronary vessels, and shouldn't be used unless the patient is below 94% oxygen saturation. Therefore, Graham would require oxygen therapy. Medication would then be administered to Graham as spoken about previously. This is not only used for pain alleviation, but also preserves myocardial tissue. Graham would then be recommended physical rest, including backrest elevation, comfort promotion, a possible stool softener, the use of a bedside commode, restful and stress-free and fear-free environment. With physical rest comes a decrease in myocardial oxygen consumption and prevents the stress response that increases endogenous catecholamine.
Within 10 minutes of Graham's arrival to ED, and with his complaint of pain, an ECG is an essential intervention to be conducted. It acts as a baseline of data, which is a highly valued portion of information as a point of comparison for health professionals. Continuing this ECG monitoring regularly and routinely produces an evolution of Graham's heart function and activity, which would coincide with his time in hospital and treatment within that time. Evaluation, being a key part of nursing care, will be facilitated with this baseline data and can be looked upon against more recent ECG traces to monitor whether Graham is improving and treatment has been effective. An ECG is a primary method of identifying if and where there is a complication within the heart as the trace that is produced can be interpreted. The specific complexes and waves can be understood to show that if an abnormality occurs on the trace, which part of the heart is accountable for that abnormality and where damage may be suggested in that area. A 12-lead ECG will be applied for the first 24 hours. The use of continuous heart rhythm monitoring for Graham with acute coronary syndrome determines whether he has acquired any arrhythmias by viewing changes in the QRS complex. The 12-lead ECG will both view and diagnose whether complete occlusion, being STEMI, or partial occlusion, being NSTEMI, has occurred, localising where an infarct is present. ST elevation reflects myocardial injury from ischemia that has lasted for more than a few minutes. The presence of Q waves indicates infarcted tissue that extends at least halfway through the myocardial wall. It is also important to compare the results of ECGs undertaken when the patient is symptomatic and asymptomatic. To accompany the findings of the ECG, blood tests can also provide a diagnosis and a baseline of Graham's condition, determining disorders of cardiac tissue and providing further knowledge for health professionals to act upon. It is crucial that during this time, communication with Graham is continuous and consistent. It is vital to keep the patient, Graham, informed about his own health, minimising the stress and anxiety of a situation that he may feel little to no understanding of.
Graham is at risk of poor peripheral perfusion as a result of decreased cardiac output from his heart condition. Our goal as nurses is to maintain oxygenation and perfusion to the peripheral tissues. The following observations will be assessed between 1 to 4 hourly depending on what is found. Documentation of these observations will be vital. First, we will observe whether Graham is hypertensive or hypotensive. Here, we view whether Graham has high or low blood pressure, and we would expect him to have high blood pressure with his condition, due to the increased workload of the heart. Here, we would question whether Graham's blood pressure is within his normal limits. Tachycardia and arrhythmias. Here, we would expect a high pulse. Essentially, we want to see normal sinus rhythm and a pulse between 60 to 100 beats per minute without arrhythmias. However, Graham has presented with tachycardia as a result of his condition. Activity tolerance. Is Graham able to perform tasks that are set to him, such as getting up to use the commode? Amount of urine output. Generally with this condition, we expect Graham's urine to be reduced. Cool, moist cyanotic extremities, an indicator of poor perfusion, and Graham is highly likely to present with this. Decreased peripheral pulse. Graham would present with this not only due to a lack of peripheral blood perfusion to his extremities, but also because blood is being redirected to appropriate areas where it is needed more, such as the brain and the heart. Prolonged capillary refill as a result of reduced blood flow to the peripherals. The following observations relate to a lack of perfusion to the extremities. As a nurse, we would hope Graham remains within his normal levels for all these observations. However, if these are present, it characterises that Graham is presenting with poor perfusion to his peripherals caused by acute coronary syndrome. Our role is to observe these regularly, keep Graham hemodynamically stable. Through these observations, we can conclude whether Graham's cardiac output is low and whether more intervention is needed to ensure his peripherals are receiving adequate oxygenation. This is also where rest comes in.
Whilst Graham is a patient in hospital, it is vital to provide care that stabilises his condition whilst in hospital, but also provides him with the tools and knowledge to extend this care outside. Acknowledging smoking and tobacco use as an aspect of Graham's life that he has the potential to change empowers him to continue on a path for better health outside of hospital. This statement by WHO outlines the significant impact that tobacco use can have and why it should be a primary focus for the nurse in improving the patient's health and quality of life, with the addition of it being a modifiable factor that he has the potential to be eliminated from his life. Smoking also has a profound effect on Graham's body systems, as Farrell brings light to its detrimental effects with a decreased supply of oxygen available for cell use and the heart's lack of fuel to account for its ability to pump the already oxygen-depleted blood. The compounds found within cigarette smoke also hinder blood flow. The nicotine increases platelet aggregation, which will impede blood flowing easily through a vessel as a blood clot can be formed and clog the vessel, preventing perfusion to tissues, muscles and cells. Damage to the endothelium can hinder the exchange of nutrients through this barrier where oxygen would usually be able to diffuse through. To assist Graham in putting the days of smoking behind him, it is vital to have a variety of avenues to do so with the inclusion of lots of support. To start with, Graham must be willing to do so and have a large contribution into his plan of care. This tactic will increase the likelihood of success in quitting smoking as he must feel he is in charge and leading his own way to a better health. It also addresses the NSQHS standard 1.18.1, where being patients and carers are partners in planning for their treatment. In order to encourage and motivate Graham to quit, he must be given a basis of education as to why. This information is vital as it is free from bias and prevents him with facts that he can choose to act on. Emphasising the benefits for his health, in particular on his cardiovascular system, directly influence his will to quit and abstain from smoking. Smoking for Graham needs to be recognised as an addiction, and because of this, it must be treated appropriately. Weaning Graham off this habit progressively is important rather than just attempting to cease smoking abruptly, which may not be as effective. Nicotine replacement therapy can reduce the symptoms of withdrawal Graham may experience with that decreasing supply of nicotine. It is important that with this plan of care, potential complications are expected. As just mentioned, the withdrawal symptoms of quitting can include anxiety and stress. Although nicotine replacement therapy will hopefully keep this stress to a minimal amount, other resources should also be considered. Having discussions with Graham whilst on shift can allow the nurse to keep track of Graham's progress, whilst also providing him with the opportunity to vent and unload this stress, knowing that he is being listened to by a professional involved in his care, with whom he should have trust in. To increase the feelings of support, Graham should be supplied with a list of contacts as specialised in assisting with his quitting of smoking, for which he can use during his time at hospital but also following his discharge. An example of this is Quitline, which is a confidential service facilitated by trained advisors. He could also be referred to a psychologist to assist in developing some coping strategies.